educative video of microsurgical management of deep paracavernous trigeminal schwannoma on the right side. This 41 years gentleman presented with tingling numbness on the right side of the face, cheek, double vision of 3 months. Examination showed no deficits, GCS 15, hypostasia in right V2 distribution, right lateral rectus pulse. With this, he was investigated with contrast MRI scan brain. MR angiography showed well capsulated enhancing tumor, right mid-skull base, medial part of the petrous apex, and the lateral part of the cavernous sinus, extending anteriorly and laterally. Tumor was suggestive of trigeminal schwannoma type A, Jefferson, Fukushima, Day, and Goel classification. MR angiogram showed medial displacement and elevation of petrous internal carotid artery. With this, he was taken up for surgery, underwent right tibial craniotomy, decompression, drilling of the lateral and medial sphenoid wing, cutting the sphenoorbital ligament, separating the and peeling the temporal basal dura mater and opening the dura and debulking the lesion, preservation of V1, V2, V3 and all the cranial nerves on the lateral aspect of the cavernous sinus and a complete excision of the lesion. These are the steps of craniotomy. We prefer to do small T-ronal craniotomy with 3 burr holes and they are joined at the zygomatic arch and dura mater is separated from the bone to avoid the injury to the underlying sylvian fissure, temporal and frontal lobes. Bone is taken out. The next important step is to decompress or drill the medial and lateral sphenoid wings. This process helps in creating a good amount of surgical space in the anterior and mid-skull base pathologies, deep-seated lesions. These are the steps of drilling or decompression of the lateral sphenoid wing, flush with the anterior and mid-skull base as shown here. The bony projections are nibbled with a micro nibbler and the lateral wall of the sphenoid wing is removed. Go gently medially, you will get the medial sphenoorbital ligament, which needs to be cut, and that helps in release of the anterior temporal basal dura mater so that we can gently peel the middle cranial fossa dura from the temporal base or middle cranial fossa. These steps are done under high illumination and high magnification, meticulously, slowly, not to injure the intradural structures. All movements should be slow, gentle, and meticulous with fine instruments. That is the medial sphenoid wing. We have reached all after removing the lateral sphenoid wing. This should be done flush with the middle and anterior skull base, reaching up to the anterior clinoid process. Now you can see after cutting the deeper part of the sphenoorbital ligament, we have reached the middle cranial fossa floor, and that's a basal dura of the middle cranial fossa, which is gently being peeled away, cutting the deeper part of the sphenoorbital ligament. Once that is done, the basal dura will be easily separated. There will be some amount of bleeding from the bone, from the temporal base, which we can stop it with the bone wax or monopolar cautery, and the basal dura is separated, and we have reached the lateral wall, anterior and lateral wall of the cavernous sinus. Once that is done, we can feel the tumor now with the suction and the instruments, the anterior part of the tumor. Now at this juncture, we thought we'll open the dura, the capsule of the tumor and start the debulking. Now after making an incision on the capsule of the tumor where it was firmer, we saw the CSF coming out into the operating field. This suggests to us that the tumor capsule is inseparably fused with the basal temporal dura mater, which occurs in many cases of basal trigeminal schwannomas. The capsule will be fused inseparably with the basal dura mater. Once that is done, the dura mater is opened, the capsule or the dura mater is opened quite wide, and the anterior part of the tumor is accessed here. Now you can see that's a basal anterior capsule adherent to the dura mater, which cannot be separated, that is taken out, and you can see the anterior part of the tumor exposed very well here. Once that is done, the dura mater is wide open along with the capsule, expose the anterior-most part of the tumor, and the tumor capsule is opened, and internal debulking of the tumor is done. That is the tumor basal part, anterior part of the trigeminal schwannoma. Intratumoral debulking is done, and that is the adherence of the tumor to the maxillary division of the trigeminal ganglion. Now, once the debulking is done, now we are proceeding with the posterior part of the tumor, which is being debulked. Capsule is opened, and the surface of the capsule, you can see the bulge there. Again, dura mater fuses with the capsule, basal dura. That needs to be coagulated extensively. That helps in reducing the vascularity and keeping the area clean. And this blood vessel comes from the middle meningeal artery branches. They are coagulated extensively, and the capsule is opened, and you can see the tumor is exposed from posterior to anterior. Posteriorly, it goes up to the anterior border of the petrous temporal bone. Anteriorly, it comes up to the anterior cavernous sinus anterior wall, and the superiorly it goes up to the tentorial edge, and inferiorly the middle cranial fossa floor. Now the internal debulking is done all around gently. These movements of internal debulking need to be very gentle, because the branches of the trigeminal nerve, that is first, second, third, that is ophthalmic, maxillary and mandibular divisions, many a times in these tumors, the tumor originates from the few fascicles of the tumor and few fascicles of the nerve, and many a times we can preserve the nerve divisions while dissecting the tumor and preserve the divisions quite significantly. Now we are going posteriorly. Always keep looking for the branches. Now you can see we have reached the trigeminal ganglion posteriorly, and you can see the nerve root there. Probably that is a maxillary division, and tumor is being separated from the maxillary division, that is V2. You can see the division there, and at this juncture the microsurgical dissection should be under high illumination and magnification, and smooth gentle dissection, peeling the tumor from the origin of the nerves, and try to preserve the roots or the divisions as much as possible. Especially our aim should be, under any circumstances, the first division, that's the ophthalmic division, should be preserved under any circumstances. That's V2 now. You can see the tumor is originating from there. There is irregularity, and you can see the nerve is irregular, and gently with this being separated from there, and you can see few fascicles entering the tumor, and the tumor is separated and removed from the second division. In that bargain, We may injure or we may damage few of the nerve fibers from where the tumor is originating, but majority of the time you can preserve the nerve root in these cases. Now the debulking is done posteriorly and inferiorly and tumor is removed. You can see the posterior part of the tumor from the ganglion where all three nerve roots originate. Superiorly, medially, the first division, that's ophthalmic, middle and inferiorly, the second division, maxillary, inferiorly and laterally, the third division, that is mandibular. Now we are going deeper and deeper, and anterior and lower part, the inferior part is being dissected and removed. Once during this procedure, one need to be very gentle and careful because at this juncture, you will get the internal carotid artery coursing below the temporal base in the petrous part and going medially to enter the lateral wall, posterior and lateral wall of the cavernous sinus, entering into the cavernous sinus. That fact needs to be kept in mind. Now we are separating the tumor from third division, that is a mandibular division, which is pushed down onto the base of the middle cranial fossa, and that can be easily separated from the mandibular division, that is the anterior superior part of the tumor being separated. We are still not seeing the ophthalmic division because ophthalmic division will be shifted superiorly and medially, and we need to keep a watch on that. So at this juncture, we bring in the endoscope and visualize the extent of resection, that is into the deeper part, posterior and superior part, which is not being visualized with a microscope. With the help of endoscope, the part of the tumor which is not being visualized in the deeper aspects medially and superiorly is removed and dissected and removed. Once that is done, now the anterior and basal part of the tumor now we need to take out, and that is the anterior most part of the tumor and basal part of the tumor, which is being debulked. Now all these steps are being done under high illumination and high magnification. Now you can see the tumor we are separating from the third division, mandibular division, the laterally and inferiorly, and separating from there is an arachnoidal plane which can be separated. That's the mandibular division entering into the foramina ovale, and that is the demonstration or showing the mandibular division of the trigeminal ganglion. Again, we bring in the endoscope and visualize the structures. Now you can see the tumor appears to be taken out in the deeper medial superior part of the tumor where we can't see with the microscope. That's a tentorial edge. You can see the trochlear nerve there, and you can see the third division, and you can see the trigeminal ganglion and the roots taking origin. That's the edge of the tentorium. You can see the trochlear nerve and the third nerve, and you can see superiorly now the ophthalmic division V1 on the medial part of the tumor capsule and the lateral wall of the cavernous sinus there, third division crossing it, and the ophthalmic division entering into the superior orbital fissure, and that is the complete removal of the lesion. We achieve the absolute hemostasis, ask the anesthetist to increase the blood pressure by 30 to 40 millimeters of mercury as compared to the induction level to see the hemostasis, because the deeper part of the skull base, we must have an absolute hemostasis. Once it is confirmed, the dura mater is closed, the basal dura mater, because it was adherent to the tumor capsule and which we had to open it for about 1 inch. Once we close the dura mater, confirm the absolute hemostasis, the area is covered with the cervical and gel foam. Bone flap is replaced, brain is lax, dura is not opened at all, a very basal anterior part about 1 inch. That too when it was stuck with the tumor capsule. Bone is replaced and fixed, temporalis muscle is closed with the galeal sutures all around and fixed scalp closed in 2 layers. Same day evening CT scan shows complete excision of the lesion, no hemorrhage, edema, swelling, and ventricles are normal. This is his post-operative clinical status on day 2, glaucoma score 15, no deficits, right sixth paresis preoperatively persists, and he is taking orally. Hypostasia of the cheek persists on days 5. He goes home with no neurological deficits. He is very happy, and the pain on the cheek has subsided. Our neuroanesthesia team, treating physician, neuro rehab team, our presence online with more than 640 microsurgical, exoscopic, endoscopic, navigation guided, educative, neurosurgical, operative, procedural videos on our neurosurgery educative video atlas. Thank you very much for viewing.